Coming. Okay. So, good afternoon, one and all. Thank you to all of you to joining with us today. Myself, Himanshu Verma. I'm a lecturer in speech pathology and audiology, Department of Therapeutics, NIPET, Secunderabad. So today I'm going to talk about on the topic importance of early identification of hearing loss. So why we need to discuss about hearing loss basically? So as per WHO in 2018, 6.12% of world population, which is approximately 466 million, suffer from hearing loss. Itself in India, 63 million people affected with significant hearing loss, amounting of 6.3% of population. As per the NSSO survey 2001, 61 per 1 lakh population suffer from severe to profound hearing loss. Hearing impairment in neonates is approximately 1.59 to 8.8 per thousand live birth, and the children, the neonates who are at risk, they range from 7 to 49.18 per thousand live births. If you see this picture, in this we are looking on the around the globe how the hearing screening is implemented, and we can see that in India it's around 0 to 2%, which is not even existing. It's very less. So what are the early signs of hearing loss? So there's a lack of response to sound, difficulty for following directions, delayed language development, frequent hearing infection, poor scholastic performance. Some other signs are like difficulty in hearing telephone, problem in noisy environment. The older fellows, the older people, geriatric population speak aloud because they could not able to have their own feedback, right? So problem in listening in television, turning up the volume of TV and radio. So these are some of the signs for hearing loss. WHO 2019 gives some indication, and they suggested that the person who have hearing loss, which identify late and got not got any intervention and rehabilitation, they lead to delay language development, under academic achievement, social isolation, high risk of injuries as they are not able to localize the sound, not able to hear the sound, and increase poverty. Why are we supposed to go for hearing screening? So when hearing loss in infants and children get undetected, it negatively affects communication, development, academic achievement, and social and emotional development. Early identification and intervention, particularly I'm emphasizing here within the first 6 months of life, provide benefit for communication and improve speech and language development, hence quality of life along with that. More than 60% of hearing loss could be prevented. And as per the WHO 2016 prevention and care strategies, 75% of hearing loss can be prevented in low middle income countries, and whereas 46% in high income regions. 30% of world's newborn and infants had minimal or no born hearing screening. They don't underwent for hearing screening itself. So here itself, in 38% of population not going under newborn hearing screening, there's a high chance they left from the hearing screening and they may have some kind of hearing loss, some sort of hearing loss. The significant hearing loss can affect 1 to 2 newborns per thousand in general population, and as high as 24 to 46%. NICU graduates are the one who got admitted in NICU because of some or other reason or high risk. But newborn screening does not identify all types of hearing loss. It may sometimes lead to miss the mild impairment, or sometimes it also means to the auditory dyssynchrony or auditory neuropathy. So we have different type of hearing loss. So we have conductive hearing loss, which we can divide into permanent and transient. We have SNHL, sensory hearing loss, and which happen because of pathology of the cranial nerve 8, that is auditory nerve, outer hair cells pathology, inner cell pathology in the cochlea. We have a neural or auditory neuropathy or auditory dyssynchrony, in which basically the function of outer cell remain intact. However, the pathology could be seen in the inner hair cell or the eighth nerve. And in this kind of population, child is able to hear but could not able to understand what happening. Those parts will have a problem in listening in the when two or three people talking together. Child not able to process the information. Child may say I'm able to hear but I'm not able to understand what's happening. and the other one is mixed hearing loss, which is a combination of conductive and SNHL. So we have some articles which got published, recent articles. So one of the article got published in the ORL journal, which suggests schooling of hearing impaired children and benefit of early diagnosis. So this study confirmed that moderate to severe congenital bilateral hearing loss has an impact on the child's schooling. And children with moderate bilateral hearing loss who are fitted with any amplification devices or hearing aid device attend regular school with good scholastic performance. There's the other article which talked on the language and the health-related quality of life outcome of children early detected with unilateral and mild bilateral hearing loss. So unilateral hearing loss, the child a person have a hearing loss in 1 year, and other is totally fine. It's normal. In that case, for initially we could not able to detect because child is able to developing some sort of language, child is able to communicate some sort of. The problem came when child is not able to localize the sound. Child have some sort of language or misarticulation issue. So in that, and child go to school and complain for a lot of things like I could not able to understand what's happening because the localization is not happening. The information is not passing from 1 ear to the because it's binaural summation happen. We hear from both ear, and then gradually at some level, at the higher level, both sounds and information get mixed up and it go as one together. So this article suggests that children with mild bilateral hearing loss demonstrate poor average language outcome than children with unilateral hearing loss, particularly at younger ages. Whereas children with unilateral ANSG showed language outcome comparable to their peers with unilateral profound hearing loss. We have some more studies here which are discussing about the why we need to focus on an early identification of the hearing loss, because the one of the study which we have right now done by Ong et al. It suggests that children with unilateral mild hearing loss were just likely as those with moderate to profound hearing loss to experience more emotional and behavioral difficulties. This means the person who is having mild hearing loss or have a hearing loss in 1 year, they have equal emotional and behavioral difficulties as the person who is having moderate to profound hearing loss. Finding indicates that early intervention, support, and medical services for children with mild or unilateral decrease is necessary to decrease the risk of poorer outcome. So the other studies talked about speech, language, and functional communication, psychosocial outcome, and quality of life in school-age children with congenital unilateral hearing loss. In this study, children scored significantly below the normative mean, more than 1 ST below, ST standard deviation below the typical range, on measure of speech perception and spatial oriented noise. So here basically the researchers try to measure the speech perception in the spatial oriented noise, and what they got significantly below score compared to the normative mean or written passage comprehension. Whereas difficulty with speech perception in noise are likely to have a negative impact on child's ability to learn effectively, basically generally in the noise space. So if the person have a poor speech perception, the child could not able to process the thing, not able to understand. The effect can be seen in day-to-day communication, in the presence of noise, in the school environment. When you go to school, noise will be there and child will gonna suffer in that condition. The other study comes from South Carolina, and the impact of meeting early hearing detection and intervention benchmarks on spoken language. So in this study, they compared the preschool spoken language outcome for children with hearing loss who met with early hearing detection and intervention guidelines to those who did not. And they actually follow the JCIA, that called Joint Committee of Infant Hearing Guidelines, that is 136. Identification by 1, 3 by diagnosis, 6 by intervention, or identification by 1, diagnosis by 2, or by 3 months of age, intervention. The children who met with this criteria, who follow the JCH guidelines, demonstrate the better spoken language outcome compared to those who did not. The other study comes from suggests early identification of hearing loss and language development at 32 months of age. So this study says that hearing loss identified by 3 months of age was positively associated with better language outcome for hearing impaired children at 32 months of age. However, the hearing impaired children still exhibit language delay. After child have hearing loss got identified by 3 months, they have better language outcome, but still the language which they have and they develop still somewhat is so lacking behind from the normative scores which we have, which available normative scores. And language outcome of children with hearing-related hearing loss were not better than those with the mild to moderate bilateral hearing loss. So means there are somewhat is no language getting compromised in both the areas. The person who is having hearing-related hearing loss also, and who have mild to moderate bilateral hearing loss also. So what are the etiology basically? So most of the 80% of prelingual hearing loss are due to genetic cause. Nearly 400 syndromes have identified who have hearing loss. And genetic cause may, if you look into that, 30% are syndromic and 70% are non-syndromic. And there are some lists given. The genes are given, in autosomal recessive, autosomal dominant, some genes which are more frequently seen, leading to hearing loss. But the interesting part to see is that mostly hearing impaired children born to the normal hearing parents. So why we need to screen, or why need to go for screening for the hearing loss basically? So we know that there's a development of the language which happen when you're hearing normally is automatically acquiring. You're not putting so much effort. So there's a study which suggests that by a vocabulary of 3 years is 900 words approximately, and by which is at 6 months is it's how it's increasing as per the age. They suggest of that. And if we could not able to hear, could not able to screen the child at appropriate age, then that vocabulary will not able to develop on the time, on the pace, and child will have a communication issue. It's not only about the profound hearing loss, even for mild hearing loss, even for hearing loss, even till mild to moderate hearing loss, we need to go for this screening as early as possible. So language development can happen on the time. And by we know something called critical age and concept and period of plasticity. It is a very old concept by Lineberg, which suggests that the brain learns very quickly when you're at early stages, right? So as soon as you're growing up, you're getting, develop, your brain also get developed, and the learning, the capacity of learning get reduced. Though we still learn, but the way we can learn at the early age, we could not learn at the late stage. So if we identify early, we'll go for rehabilitation early within a critical age area years, that is approximately 3 years. The child will develop better. The child who diagnosed at the later stage and get rehabilitated at the later stage. Hearing screening significantly lower the diagnosis of moderate to severe hearing loss. Of course, if we could able to screen it at early as possible, we could able to look, because sometimes we can avoid the conductive pathology, and we can avoid a lot of things with that, because if we are hearing screening is done at early stages, and we could able to identify the child have a conductive pathology, a child have other sort of pathology, we could rehabilitate at early as possible, or we could provide medical treatment or surgical treatment at early as possible. There's a simple example come from France. There's a reason called Champagne-Ardennais. I may be pronouncing wrong. Where the median age for diagnosis of hearing loss, hearing impairment, reduced from 17 months to 10 weeks after implementation of UNHS. UNHS is nothing, it's called Universal Unit Hearing Screening Program. So after implementing Universal Unit Hearing Screening Program, the diagnosis of hearing impairment, which was happening before at the age of 17 months or beyond that, it reduced to 10 weeks, which is quite interesting thing, because again I'm repeating same thing because it is very essential. As early as possible, we screen, we diagnose, we can rehabilitate. Early rehabilitation lead to a lot of good things: good scholastic performance, good speech and language development, good quality of life, and it's also reduce the stress of parents. Lockheed studies are something called longitudinal outcome with children with hearing impairment. It is a very famous study which is done between 2002 to 2007 in Australia, basically. And they showed children who fitted with hearing aid or cochlear implants have better perception, better speech perception, better language, higher cognitive abilities, and functional performance. So those all study indicating somewhat and somehow we have to emphasis on the early intervention and early diagnosis. Now, whom to screen? Ideally, we have to screen every children who's getting born in the hospital or in the home. So we have to screen every children. But because India is a huge population and targeting universally, initially level it may be tough. But what we can do, we can at least target the high risk people at the initial level. Of course, gradually we need to expand and go for universal hearing screening. But initially we can target at least those baby who are at high risk. So around 50% of profound hearing impaired children would be missed with target risk factor based screening. Now what happened? However, we are targeting no high risk, but if we target that also, we could miss children who are at having hearing loss. That's a high chance for that, right? So at the last stage, we have to go universally, but initially we can target high risk children. Now, when to screen? At what is the right time to screen? As early as possible, as close to discharge as possible. Preferably 12 hours or more after birth. As soon as child got delivered, within and 12 hours got complete of his first day, we can go for hearing screening. But still, when we go practically, it's sometimes what happens, child have a decrease in the ear, amniotic fluid in the ear. In that condition, it becomes tough. So at least 12 to 14 hours, within 12 to 48 hours, we have to go for hearing screening just to look for the child is passing the screening or not. It is a very quick test when we do when I say screening, it's not the long test or taking time consuming test. It's a very quick test which happen very immediately. It's just hardly 5 minutes to 10 minutes test for both the ear. And when we do the screening as early as possible, it provides us time for the second repeat and for the proper diagnosis. And the preterm, because see, there are a lot of preterms which happen that they need to be screened after 34 weeks of gestational age to reduce the risk of false positive. False positive means the child may be normal, but because of some other conditions, maybe debris, amniotic fluid in the ear, because of those conditions, child still should have failed. So just to reduce the risk of false positive, after 34 weeks of gestational age, we can go for the hearing screening. Now for readmission within first month of age, like example, the children who got discharged, they got passed, but they again got some meningitis during the, within 1 month or within 3 months of the age. They got meningitis, they got pneumonia, they got jaundice, they got some other, you start observing some regression in that, child is not developing properly. In that condition, we have to go for rescreening of the hearing also, even after child passed the first screening. And at school level, we have to go for multiple repetition because school age children at high risk of medullary pathology because they are, scratching their ears, they're putting some pencil in the ear, they're, those because of those stuff. So children have high chance of medullary pathology. And if they have high chance of medullary pathology, it of course going to affect on their day-to-day life. It may also lead to poor scholastic performance. Now, as per JCIH 2007, the guidelines was like 1 month we have to go for screening, 3 months we have to go for identification, and by 6 months intervention should be done. But now with the advancement and with the time, JCIS 2019 indicate that by 1 month we have to screen a child, and by 2 months we have to identify or diagnose a kid with the hearing loss, so we can go for intervention as early as possible by 3 months. So now why this change came? Because infant can receive early intervention for auditory or visual access to language, and objective audiological testing can be completed without sedation. Because when we go for diagnostic tests, mostly in infants, we go for auto like ABIA, the BERA, and for BERA we need to sedate the child just to complete the test. Now, if we are doing that early, like 3 months of age, we don't need to sedate a child. Child have a natural speech, and during that time we can conduct the diagnostic test battery. Now, to screen hearing, we have some tools for screening, which is recommended by JCIH, also recommended by the ISHA, Indian Speech and Hearing Association, ASHA, American Speech and Hearing Association, and by the UNICEF Committee, and many other platforms. So it's something called Auditory Commission, and other one is automatic auditory balance and response. So OA, what happened? It's basically it's a non-invasive process where we just keep the ear tip in the ear and make the seal, and it should be done in the silent environment. The noise should not be there. If noise floor is more, we could not be able to get the OA. And OA, what do they? They collect the responses from the outer ear cells. If we can get the response from outer ear cells, and to get that response, the OA itself emits some sounds which go to the inner ear, and outer ear cells respond to that, and from after responding to that, the OE, the instrument, take the responses of outer ear cells and say if it's showing pass, it means outer ear cells are functioning well. Where it's showing refer, so it means outer ear cell is not functioning very well. The other one is automatic ABR. It's a very quick test. We just or instead of that, we can use Barafon also. It's usually done at 35 dB NHL. And what happened in that, we just putting some electrodes, and after that, we just look for the pathway. It's a very screening. Basically, wave fifth got traced here. Again, it show pass and therefore it not estimate for hearing threshold. It not talk about any base morphology and other things. It's just saying child have hearing loss, yes or no. That's all. In the school-going children, we can do the pivotone audiometry basically for 500 Hz, 1 kHz, 2 kHz, and 4 kHz for those 4 frequency to assist for the and to roll out for the high frequency hearing loss and the hearing loss. Now we do have some national programs which is running in India. Something is RBSK. RBSK is Rashtriya Bal Suraksha Karyakram. It's basically run by the National Health Mission, and it's involved age group of till 18 years. However, when we look into that the program, it's provide free hearing aid and the cochlear implant, and they have a kind of tick list and some eligibility criteria. If child is falling in that eligibility criteria, child can get the free hearing aid and free cochlear implant also. They fund basically till some amount. The other one is National Program for Prevention and Control of Deafness. It's launched in 2006 to control the deafness as early as possible. And the other is ADIP scheme. Under ADIP scheme, initially till the year of 2015, hearing aid was a provision which we used to give for beneficiaries. Initially, it was body level hearing aids, and then gradually the BT also got included in that. After 2015 approximately, cochlear implant also got involved in this scheme, which is kind of wonderful because so cochlear implant is basically a surgical management. What happened, the implant got inserted in the inner ear, and the acoustic sound go directly to the inner ear and bypass the outer and middle ear. So it will give the better output to the directly to the cochlea, and child can have a better speech perception. And in 2015, the first time it's got included, and still it's going on, and till the age of 5 years. If child is till the age of 5 years, you can enroll in that, and there are the eligibility criteria also. So now, what we can conclude from this, presentation, basically, early diagnosis is the key to early intervention. If we could able to diagnose as early as possible, we could go for early intervention, right? And to diagnose early, we have to have a screening program, which is missing in India, and some of the states is implemented. The first state which implemented is Kerala, that's called Butterfly Corner, where they have Butterfly Corner in most of the nurseries and primary healthcare and the tertiary healthcare setup. There's a small corner where a child got screened out for the hearing, just after the birth. So followed by some other states also just trying to implementing, but there are a lot of limitations and lots of struggle happen because we have a huge population and the manpower to doing early screening is less. So when we go for early screening, it's related to early diagnosis. Early diagnosis is to early intervention, and if early intervention happen, the better speech and language development happens. So right, it lead to better speech perception skills. It lead to better cognitive development. It lead to better adequate emotional development, psychological development, psychosocial development, right? It lead to better phonemic to graphic conversation skills. Now, what happened when child having poor speech perception, they have a poor phoneme to graphic conversion. Phonemic to graphic conversion, nothing. When I say A, the sound of A is A. I can have a alphabet, it may be Hindi, in Telugu or English in my mind, and I can write it out. That kind of correspondence I do have, right? But this kind of correspondence is missing somewhat in someone hearing impaired children, because the speech perception is impaired. They could not able to correlate. For them, pa, ba is kind of similar, because when I say pa and ba without any or output. I'm not. I'm just saying lip sync kind of thing. You will not able to understand. I'm saying pa and ba. Same thing happened with a kid. So maybe you're saying pa, they may be listening as a ba. So that kind of correspondence is not there for them, and that's why they have poor writing and reading skill. They do a lot of error in spelling mistakes, right? So when we go for early intervention, that phoneme to graphic correspondence increase, their auditory memory increase, their phoneme to graphic correspondence, buffer got increased, and they have a good writing skill, good reading and writing skills, hence good scholastic performance. And the child have a good speech perception that will lead to good speech production. When I'm able to perceive properly, I'm able to utter properly. The production task will be better with that. And it lead to timely integration, which is very important in school, because what happened, hearing impaired population, it's kind of hidden disability. Initially, you could not able to identify if its hearing is not done, right? So hearing problem is a hidden disability, right? So, and with that, if it's not timely got diagnosed, it's not got timely rehabilitated, lot of issue will be there, and we could not able to integrate child in a normal schooling, which take lot of time, lot of effort. If we'll have a early diagnosis, early intervention, we could able to integrate a child in time in school timely, and which lead to better quality of life, not only for kids, for the parents also, because parents equally suffer when child have a hearing loss. Acceptance is tough, and the struggle they have, in order to have a hearing aid or amplification device or speech therapies, language therapies, and other sort of therapies. So when we could able to go for early screening, early diagnosis, early intervention, we cut down to a lot of things. We are also reduce the cost. Cost also get reduced, and hence less stress to parents, less stress to family, and the better quality of life. And with that, I should say, I want to conclude: ear and hearing care for all. Let's make it a reality. Thank you. Ask any doubts, sir. I don't know where it is, sir. So, any doubt is there in that? Like, if the questions are there, I can take up, or we can discuss.
Hello, good afternoon, sir.
Yes, please. Good afternoon.
Yeah, I'm Atiya Sabha, physiotherapist.
Okay, ma'am.
Yeah, so I just wanted to ask the screening tests which are mentioned by you at 1 month and 3 months,
Yes.
are they implementing in all the maternity hospitals for now, or it is the choice of parents?
So the problem over here in India, we have a large population as a tool, and as per the unit that's called Universal Hearing Screening Program and JCH, we're supposed to implement. But in India, it's not yet implemented everywhere. It's become a choice of parents. But yes, I can say in India, the state called Kerala, which are the first state where you can have, you have to have go for hearing screening. That's called butterfly corner. It's compulsion over there. Along with that, I can say in Chandigarh, PGI also include that now. Initially, they have a high risk, and right now they are going for universal hearing screening program. Along with it in Delhi, some of the regions is going on, but it's not universal. It's not all over the India actually. So we need to implement. It's quite tough, but we have to work out on that when we are working on that gradually. I hope we'll achieve that.
Oh, okay. Because if it's mandatory, then every child would have the screening done as a part of, as we have vaccination mandatory. If this screening also is mandatory, it would be fruitful for every child.
So what you can do if you're working in a tertiary care setup or primary healthcare center or maternity center, you can use the UNHS guidelines or JCH guidelines. It's a part of hearing screening and overall screening program. So in that, which you can give to your HR of your hospital, and then you can implement. Because in PJ, I was before in PJ Chandigarh, and that time we faced the same issue. And what we did at that time, we actually may implement same thing along with the vaccination procedure. Along with the vaccination procedure
Right.
itself, we implement that, and it's running very well right now over there.
Oh, that would work out then.
Yes.
Okay, thank you, sir.
Thank you, ma'am.
Good afternoon, sir.
Good afternoon, ma'am.
Sir, there is one question. Suppose if a child is having a speech problem
Mm-hmm.
and he's exposed to only one language, will that be better, or if he's exposed to 3 or 4 languages? Because the child is going to school where he's exposed to different languages, Hindi, English, Telugu. So, what do you suggest as a therapist?
Okay, so ma'am, what happened when, as in therapist, is a lot of studies are there. The language, if there are 2 or 3 language child is learning, they will be not gonna much issue. But because child have hearing loss, what we suggest initially you can start with one language, then gradually you can start exposing to other language. Restriction is not there, but for initial level when you're starting the the therapeutic part, so you can start with one language initially, and then gradually you can expose to other language. Because these are studies which suggest that if we have a multiple language input also, this is not going to affect the development or the speech language issue. So, but just to have better speech and perception level initially, you can start with one language, but gradually you can implement others.
Thank you, sir.
Any other query, please? I can see Mr. Lingaraju's hand raised the hand. Is there any question from Mr. Lingaraju, Nagalakshmi? So what can I say? Because I'm not getting any question right now. So the thing is that implement hearing screening is actually not an easy task. It takes a lot of struggle, a lot of effort, because of the large population we have and different mindset of the professionals around in the India itself. And I can say a lot of even medical professionals are not aware of that. So to make them understand and to make them understand like what is the significance of UNHS as a